The Down Syndrome Association of Northeast Ohio presents Dr. Laura Sifrabine, their Medical Outreach Director, and Dr. Moya Peterson, who runs the Adults with Down Syndrome Specialty Clinic at the University of Kansas Medical Center, discussing Global Down Syndrome Foundation's healthcare guidelines for adults with Down syndrome.
By viewing or participating or accessing any information referenced or linked, you agree that DSANIO employees, volunteers, or other associated persons or entities are not acting as your medical professional or attorney. Information and/or responses that you may receive from this website, webinar, electronic mail, phone, or in any other manner do not create or constitute a doctor-patient or attorney-client relationship between you and DSANIO or any employee, volunteer, other person or entity associated with DSANIO. Information received from DSANIO employees, volunteers, or other associated persons or entities, or from this webinar website should not be considered a substitute for the advice of a medical professional or attorney. DSANIO does not provide any medical or legal advice. You should consult with your own doctor, attorney for medical or legal advice. This webinar or website is a general service that provides general information over the internet. The information contained in this webinar is for general information purposes only and should not be construed as medical or legal advice under any circumstance.
Hi, I'm Chris. I think I just said that. Welcome to DSANIO's webinar on the Global Medical Care Guidelines for Adults with Laura Sifrabine and Dr. Moya Peterson.
My name's Moya Peterson. I am an advanced practice nurse practitioner. I'm board certified in family medicine. I work at the University of Kansas, if you couldn't tell from the Jayhawk over my shoulder. And I know y'all are in Ohio, but we're in a different conference, so I think that's okay. I also saw Sue's room with lots of instruments. And if you could look around my office, you'd also see a lot of instruments in my room, none of which I play very well. So I am, when I went through to get my PhD in nursing, my dissertation was with adults with Down syndrome. And I found out that there was a real lack of specialty care for them once they graduated out of pediatrics. We have an excellent children's hospital here in town, and we really didn't need any more pediatric input, but we just didn't have anybody for adults. And I found out also that we're kind of the only, so I established an adults with Down syndrome specialty clinic here at the University of Kansas Medical Center in Kansas City. We're housed in the Department of Family Medicine. I found out that we're the only program that offers that kind of care between Denver and Chicago. And so we draw from a lot of states here in the Midwest. I also teach part-time over in at the nurse practitioners over in the School of Nursing. I started my clinic in about 2009 and seen around somewhere around 400 patients. I am proud of the fact that we're the only nurse practitioner staffed administrated clinic in the United States. We're located right on the state line of Missouri and Kansas, and that creates some issues sometimes between the states with Medicaid and insurance and referrals and whatnot, but we figure it out. We have access to all the specialties in our tertiary system. And the other nice thing that happens is that the residents that I work with in family medicine also help take care of my patients. And so they get some introduction to adults with Down syndrome, as do the people in the hospital. And I'm really proud to say that my folks get really good care when they're in the hospital. The nurses and the docs take really good care of them there. And also this carries over to a lot of specialists that I refer to in KU because they haven't worked with too many adults with Down syndrome. And I'm also proud to say they do a good job there as well. We have many small and rural communities in Kansas and in Missouri, and many times there's only one provider to take care of everybody in town or everybody in the county. And so I was so pleased when I was asked to participate in these guidelines, because I think it's very important for those kind of communities in Western Kansas mostly to have access to some kind of direction on how to take care of adults. And so when Global asked me to be part of that, I was so excited. I was the only nurse on a panel of some very, very bright and well-published docs that take care of adults with Down syndrome. And so I was pleased to be a member of that original author group. So we try to give some direction to those docs out in those primary cares that may have one patient, may have two patients with Down syndrome in their community. And live quite a long ways. Some of the small cities in the western part of our state are about 8 hours from Kansas City. So it's a long drive for them if they can't get the care that they need. So I want to thank you for inviting me to talk tonight. Usually Brenda Gilaro is here, and she kind of does this first part, but she couldn't make it tonight. So she asked me to do it. Global is located in Denver and was the leader on coming up with these global medical guidelines. They undertook the price tag for this, and it was not an inexpensive effort. And Bryn Gilaro took care of getting us all together, and it was like herding cats. It just was hard to get us to find a time when we could all get together, and she just worked diligently to do all of that. And there are many things going on, and so we'll talk about that in just a minute. We worked probably close to 3 years to come up with the first set of guidelines, and was published in JAMA, which we were really excited about because it's a magazine that most all providers read. Even, you know, so we felt like that would give us good circulation and good to get to the docs that needed to get to. It's prestigious, it's trusted, it's highly, it's very carefully edited and very carefully editorialized, so that make sure that we get all the right information in there. We put everything we could think of in that publication so that it would be of strong use to the folks. So we started out with a huge list of things that we all thought ought to be covered. There was 12 of us, and all the things that we thought ought to be covered. And we kind of had to narrow them down because we couldn't do all of them this first round. And so here are the 9 topics that we covered. Behavior and mental health, which we know is a huge issue for most of the parents with adults. Most everybody knows that our guys developed some dementia at some point. And so it was it's a huge issue. So we felt like it ought to be given some real important direction right off the bat. And then we talked about dementia, we talked about diabetes, some cardiovascular disease, obesity, which we know is a huge problem, atlantoaxial instability, which we know has been a consistent issue with Special Olympics, osteoporosis, thyroid disease, which we also know is very common, and celiac disease. So those are the 9 that we undertook this first round. Now, if you had the opportunity to download the JAMA article from the Global things, it's a lot of medical stuff, a lot of medical words, a lot of complicated text. And so Bryn and her staff and with input from us worked very, very hard to come up with a family-friendly global guideline. It kind of takes out a lot of the medical words so that you can understand what we're talking about and what we're looking for. There's some terms that are defined, and the same topics are covered. It's just covered in a format that's just easier for families to use. And here you can kind of see what that looks like. It's printed in a separate booklet that you can order, or that your provider can order. So the first big issue, I'm just going to address kind of some of the issues that I was directly involved with. The atlantoaxial instability, as you all know, for years when your kids wanted to do Special Olympics, they had to have x-rays of their neck because we were a little worried about atlantoaxial instability. And we worked with Special Olympics on this one some, and they said in all the years that they have done Special Olympics, they've never had anybody with an injury because of AA instability. So they felt like it wasn't necessary anymore to do those x-rays to clear them for Special Olympics. And the other issue that we came up with is that the x-rays that are done are very subjective in how they're read by radiologists. And so we think some of our kids were probably diagnosed with AAI when they really didn't have it. Maybe some had some and they again weren't diagnosed because of just the way the subjectiveness of how those x-rays are taken and how the x-rays are read. So we've come up with the recommendation that unless the child, the adult is experiencing some sort of symptoms, there's really no reason to worry about AAI anymore. So those symptoms would be, if they complain about numbness in their hands or they're not using both sides of their body equally, or you see something that doesn't, that looks like a pinched nerve, or they're complaining about that, there's really no reason to be concerned about that anymore, that we think it's much more stable than we thought at first. So unless your child is symptomatic, we don't worry about that. And we're recommending that you not worry about that anymore. And actually Special Olympics has taken that off of their form now, to rule that has to be ruled out before they can participate. Diabetes is the other concern. We recommended that they get screened using an A1C or a fasting blood sugar every 3 years, starting at age 30. And unless that they have obesity, which a lot of our guys do for various and sundry reason, and then maybe performing every 2 to 3 years, beginning at age 21. That's quite a bit sooner, as you'll see in the next slide, than what we recommend for what is recommended for neurotypical adults. But we felt like it was important to start earlier because of the advanced aging that our guys seem to experience, and because of the weight issues that we have. We feel like, and there's also some concern that there's some autoimmune disorders that our guys seem to carry to be at risk for as they go through their life. And so we want to be alert to any kind of those kind of changes. And this includes type 1 and type 2. They develop both of them. And so we keep an eye on it. Personally, I screen every year I do blood sugars and what have you, A1Cs if necessary. But certainly we start a little bit earlier than that. This is a picture of me and one of my friends named Jack, and we were walking down the hall together, and his mom took a picture. I don't know that I was real fond of taking a picture from the back of me, but I really like this picture of him and I. So diabetes is a very common concern because they do have a lot of the risk factors, the obesity being one. And we know that they also have some autoimmune disorders and immune deficiency. And so we know that those are both huge risk factors for especially type 2. And then we think, I was surprised as we did this work that the complications that we're always told happen hasn't been proven that they get better if you have good control and if you start early. But we think it does. We think it does. And so things like nerve damage, eye damage, kidney damage, the things that are related to very tiny vessels that get clogged when the sugars get so high and the blood gets thick, and then those little vessels get clogged up and they cause damage. We think that early diagnosis and good control will manage that so that they don't develop those kind of complications. And we think that treatment far outweighs the positive parts of treatment far outweighs the negative parts of treatment. With type 2 diabetes, there's several medications that we can use that don't cause low blood sugars. And certainly, if you think about treatment for type 1s and type 2s, we don't drop their sugars down to, down to way down and tight control. We let the sugars run a little higher because we know our guys have trouble telling us when they're not feeling good, and And so we don't want to run those sugars too low, but we certainly have a good medicines with minimal side effects that can manage those situations for us. So it's good. The ADA, recommends screening for neurotypical adults at age 45, and those that are overweight and obese are screened every 3 years. But with our guys, we recommended it at 30, and that if they're overweight or obese, we recommend at 21 and on a little more frequency, so that we can catch this early and get it controlled. So that's important. We start a little bit earlier and a little bit more often. The potential harm versus the potential benefits are minimal. The diabetic life is, although inconvenient, it's a healthy way to live. It's a healthy way to live. And so if we can minimize the complications from the high blood sugars, there just aren't many risks. But certainly every adult needs their own plan. Some of my guys, can't swallow pills. And so we have to look at other ways to handle things. Or I certainly don't want to put them on medications that would cause low blood sugars. I want to keep their sugars up so that they don't get in trouble. And so you have to really individualize the treatments and individualize the regimen for them. They also note that antipsychotic drugs and childhood cancers, which are more common in our guys, also put them at risk for diabetes, as well as some positive family histories. So, many times we treat some behaviors and some mental health issues with antipsychotics, and that puts you somewhat at risk to develop diabetes, more so than when you're not on those. But we certainly need more research on the complications of diabetes, and every guideline that you look at, it's going to say we really need more research on this. When they started paring down, there just weren't very many studies that looked at our guys with diabetes or at our guys in the research that were adults. There's a fair amount in kids, but not in adults. So most every guideline needs more research on it. Obesity is a big problem. Christopher doesn't look like he's overweight, but it is a big problem in this population. And not all people are. Some of our kids are not. And, they eat what they want and they do fine. But other kids just gain weight for various and sundry reasons. We think probably that their metabolic rate's about half that of other adults without Down syndrome. And so this is one of those things where I wish I'd have written this down, but I didn't. I read a study that said they sat 3 people on the couch and they all did the same thing and they all ate the same thing, and the kids with Down syndrome gained weight and the kids without Down syndrome did not. So that tells you that they don't use what they eat quite as effectively as neurotypical folks do. And so they'll gain weight less than or faster than neurotypical adults. So it's just a constant struggle for all of you. One thing we did talk about was, is there a target BMI for neurotypical adults? We think about somewhere between 20 and 25 being a good BMI, but we're not sure that that's accurate for adults with Down syndrome. I think there was kind of a feeling that it might be a smidge higher, but we just don't know what the smidge is. We don't know how much higher it might be, or if we need to stay within that target, but it is really difficult to get our guys down to, for most of our guys anyway, to get them down to a 25 BMI. It's difficult for me. What can I say? We haven't had the safe and effective treatments. We haven't had too many. So far there isn't too much. I've heard talk about, can we do bariatric surgery on them? Should we do bariatric surgery? Should we put them on the medications? I don't think there's any consensus on what the best treatment is outside of lifestyle interventions. And so it is really hard. I don't know that I've heard too many that have had bariatric surgery. I'm sure there's some out there somewhere, but I haven't heard of too many. But certainly it makes you wonder with so many of them having some kind of congenital heart defects, if carrying that extra weight is hard on those hearts. We certainly know that it's probably hard on their joints, but we're just not sure what the most effective treatments are for them yet, or what our goal is. Here you can see what a scarcity of literature there was. There were 3 clinical trials and 2 reviews of literature, was all that we had to go on. And it showed that physical activity, aerobic exercise, and resistance exercise did not always lead to weight loss. There's a group of folks here that do a whole lot of work in exercise and weight loss, and they give the kids Fitbits, and they have Zoom sessions, and they have in-person sessions. And a lot of my guys will lose a little bit of weight, and then as soon as those classes are over, they gain it all back. And so it does, even some of my really active guys who are in Special Olympics and who are really quite busy have a hard time losing weight. So we're not sure that it's not just exercise. So all we could do here is make a statement of good practice. Means that kind of meant we're not really sure what the answer is, and there's no research to back us up one way or the other, but we know that a healthy diet is imperative, and regular exercise is important, and calorie management, and not just to count on the benefits of exercise to lose weight. That it's going to take more than that. Even when you watch what they weigh, I had some folks come in, and the girl and dad exercised every day together. They did aerobic and anaerobic stuff, and she's very active. They watched what she ate, and she still continued to gain weight. And we're just not sure why that is and what mechanisms in function. And some of my folks, just hate to tell their kids no when they want to eat something, or when they go somewhere. And it's just really hard on several different planes to watch. And some of my kids sneak into the kitchen at night after their folks go to bed and the house quiets down. They get up and sneak into the kitchen, and that's hard to manage too. You can't be up 24/7 watching what's going on. So it's just a very, very difficult place to be. So those are the ones that I was involved in. Certainly there are other of the guidelines. What's next? We've completed a one-page checklist of all the things that should happen at what age, and what should be screened at what age. And I think all this is on Global's guideline, or Global's website. If you go to the Global's Global Down Syndrome Foundation, you can get all these toolkits. So it tells you what screenings and what should be done. There's also the diabetes toolkit. It gives you what the BMI is and what blood sugars ought to be. So that's helpful. And then I think Dr. Tyler, Laura said that she talked to Dr. Tyler. I think he helped develop the celiac disease checklist as well. Celiac disease is not something that many primary care providers think about, but is pretty common in our guys. And so we need to think about that. It's always important, if your guys' behaviors change, for us to rule out things like celiac and hypothyroidism and some of those things before, and sleep apnea, before we just assume that it's a behavior, because some of those things can appear as a behavior issue. I always tell my folks, when you've got X amount of coping mechanisms, then you pick one of those, and it may not be appropriate, but that's the one that you're going to use to tell somebody that something's hurting. 2 more are in progress. They're working on a dementia one. As you can imagine, that's a very complicated, the dementia and the behavior health ones are very complicated and hard, because it seems like, I tell my students, if you've seen one person with Down syndrome, you've seen one person with Down syndrome. They all kind of have different things and the different ways they approach it. So the dementia and the behavior health ones are pretty difficult to come up with, but they're working on that. We are translating the guidelines into a number of languages. You can see the ones here that have already been completed is Spanish and Japanese. Part of the Japanese was because The CEO of Global Guideline I believe she's of Japanese descent. And so she was anxious to get that in a language for her population. And then they've got a number of others that are going to be first, but you can see there was 20 different languages that have been requested to have the guidelines translated into for their population. And then finally, we got that all done and we published it and we all clapped and patted ourselves on the back. And then Bryn said, okay, let's start the next group. And we all agreed that our work wasn't done. So we've kept working on this. And here are the next 5 topic areas that we're looking at. Sleep apnea being a huge problem in our guys. And we also know that with some of the facial stimulation that a lot of our guys can't tolerate the CPAP masks. And so the Inspire mechanism, whether or not that works. So there's just a lot of issues around sleep apnea right now that we're trying to work through. Solid tumor cancers that we're trying to work through. The leukemias in adulthood, not as common as it is in children, but still there. What physical fitness means in this population. I'm sure we're going to think about the BMI business then. And then vision and eye health. And again, there's conditions like keratoconus, which some of you may have heard of, creates issues. We have kind of early onset cataracts with our guys. And then some of our guys just don't tolerate glasses very well. And so you wonder how well they're seeing. So we're trying to figure out those kind of what the recommendations are for care, as well as update the 10 that we already have done and then add these 5 more. And we kind of plan on just every couple of years adding a few more topics. We have lists and lists and lists of things that we want to consider and put out there. So if there's any questions, I'd be happy to answer. I went through those pretty fast, but I'll be happy to answer any questions.
I'm going to try to share my screen and put that disclaimer up if I can find it, but please, does anybody have a question to start off with? You can raise your hand or just unmute and ask the question, and then please mute again so we can hear Moya's answer.
Lori? I'm sorry, did I interrupt somebody?
I don't think so.
Looked like Lori had her hand up, so I just wanted.
Okay. I was going to say, can you explain for people who don't know what the Inspire is? Can you explain what that is?
Sure. You may have heard it. It's advertised on TV now. It's an implant, sort of like a defibrillator, and it has a wire that goes up into the nerve up in the soft palate and into the diaphragm, and it picks up sleep apnea through those. And you turn it on with a remote, and then you go to bed. And when it picks up that you've quit breathing, it stimulates that soft palate to raise. When it picks up the diaphragm's not working and the soft palate raises. And that's basically what the CPAP is trying to do, is to keep that airway open. And so this does it through nerve stimulation. And so then they don't have to wear the mask. And I think that's going to be helpful in our population. But we've done some here at KU. I know that there's been other facilities that have done some, but certainly not widespread. But I certainly think it's going to be the answer to those kids that can't tolerate the stimulation of the mask and feeling closed in and not liking it. So, but it needs some minor surgery that you have to do, and so it's not without its risks with anesthesia and placing that as well.
Thank you. And in terms of the with the behavioral health, we hear sometimes about 20-year-olds, 25-year-olds being diagnosed with dementia. Is that really something that happens, or what? If it's is a younger person, what kind of things do we need to think about?
We don't think so. If there's one thing I've learned from Dr. Capone, it's that you need to look for something else. If it's a 20 or 30-year-old that's experiencing some issues that would seem to be dementia. When they get into their mid to late 40s, and certainly in their 50s, then dementia is a reality. And we have to think about that. But in their 20s and 30s, it's just not that common. And so you need to look for other reasons. And sometimes, I mean, you certainly have to rule out some of the physiologic things like celiac and hypothyroidism and sleep apnea and some of those issues. And then you look for some, you know, our guys are blocked in. I mean, they need schedules. And, you know, when those schedules get upset, they can get depressed, or they can get very, very anxious. And maybe that's what's causing the issues. Or someone close to them has passed away and they're depressed. And so you need to look for other issues besides dementia when they're in their 20s and their 30s, because it's not very common to see dementia in that age group. I do see patients, you know, not infrequently that say, you know, the doc put him on Aricept because he thought he was having dementia, but I always look for something else. Somebody asked about regression. That's a tough one. We're looking at that. Dr. Chacoin is kind of leading that out of Chicago. Regression is another difficult topic that is much more common in the younger folks. And that's just when the kids stop developing and then start to go backwards. They quit doing things that they did before. And, you know, they used to talk and now they don't. And they used to do this and now they don't, and they can't get dressed and they just get stuck somewhere. You know, they'll go and sit on their bed and get stuck. And so we're looking at that and where that fits into this whole behavior health, dementia, where that all fits in. So yeah, we're looking at regression. We have a group that in the Down syndrome medical interest group that's looking at that and what we can do about that and how we can figure out what regression is. Dr. Santoro, Jonathan Santoro, is very active, as is a couple of the guys in Denver, looking at that and seeing, is there some way we can determine what's regression and what's not, but we haven't quite figured that out yet, but we're working on it.
And with DeSanio, I should have introduced myself. I'm the new medical outreach director. I'm a pediatrician, but we are trying to form strategic partnerships with all of the local hospitals, Cleveland Clinic, University, Metro, and Akron, to try to identify providers and systems of care to help with our adults with Down syndrome. If people have providers that they like for their adult children, if they could drop the names in the chat of specialists or primary care providers, we are trying to form what we're calling DeSanio Community of Care, which will be an informal network of providers that we can support through education and a newsletter, and then use those providers to be resources for our families. Because we know, and you know, I'm a pediatrician, but Christopher's had some significant health issues, as all our children do as they age. So that's really one of our strategic goals of DeSanio, is to really improve and support the care for adults with Down syndrome in our area, and also reaching out across the state and across the country, especially on things like regression. I talked to Dr. Eileen Quinn in Toledo this week, who's one of the experts. And yes, thank you. Somebody in the chat said there is a very good podcast, and if you Google Dr. Santoro or Dr. Quinn, or our website, which just got all the medical aspects updated, there we have specific links on regression, and we're also going to make those all our website links available on the Parent to Parent Network on Facebook. My good friend Rich is going to help us.
I believe Dr. Quinn has a youngster with regression, does she not? And so
Yeah.
she's been very interested in the treatment and the diagnosis of it.
Yes. Yes. So know that Desanio and with global support, and we're really working on these issues. So I'll drop my email in the chat. You know, Desanio cannot provide medical advice because we're not your doctor, but we can help you with resources. So I'm trying to, yes. Dr. Peterson is going to send the slides to me, and then I will talk to Tony about getting our executive director, and this recording will be on our website and likely on our YouTube channel. And I'm just making sure. They're way back here in the chat is, have you done any work on sleep issues in people with Down syndrome? I'm not sure if that's sleep issues besides sleep apnea.
You know, some of my guys do have issues with sleep. First of all, I do believe that they're night owls. I don't know how many of you guys, your kids stay up till all hours of the night and then want to sleep late in the mornings. Is that true for people? Seems like the folks, yeah, the folks I talk to, their kids will stay up till 1 or 2 and then want to sleep till 10 or 11. And so there's lots of ways to deal with this. Sometimes it's due to anxiety. And if you treat the anxiety, they'll sleep better. Sometimes it's just a lack of routine. Sometimes it's, you know, it's just been upset. Sometimes the kids, you know, get diagnosed with things like sundowners, and I don't think that's it at all. So it can be a variety of issues, but some of the routine things like melatonin will help. Sometimes a little Benadryl will help. Sometimes if you have a depression alongside, some of the antidepressants will help. So there's a variety of solutions to that, but it's a pretty common issue that they can't sleep at night, or that they're up any number of times during the night, especially if they're hungry. They get up and sneak out the kitchen.
Is there any, I know this is probably coming up, but advice on like menopause, mammograms, like women's health issues? I've read some things about that being different for adult women with Down syndrome.
Yeah, menopause occurs around the age of 41, which is about 10 years earlier than for the neurotypical woman. But as you all know, there's a broad number of years on either side of that number that may or may not occur. At this point, Dr. Barry, oh, that's just awful. His name just left me, Barry, out in Denver.
Martin.
Barry what?
Martin.
Yes, thank you. Barry Martin out in Denver has done a really nice job. And right now we think that our ladies are not at risk for breast cancer, and that the general rule of thumb is they do not need mammograms unless there's something that comes up, you know, if a lump is felt or something. The only time I think about that seriously is if they have a first-degree relative. So, you know, if you've had breast cancer and you're concerned about your daughter, then we think about that. A lot of my ladies won't tolerate mammograms, so if we have to do something, we do ultrasounds instead. But in general, our ladies don't develop breast cancer, and so there's really no need to screen with mammograms. By that same token, if your daughter has not been sexually active or has not been sexually abused, there's really no reason to do pap smears. because you have to have been exposed. And for most of my ladies, it would take general anesthesia to get through that particular screening test. So there's really no reason to put them through that if they have not been exposed. So I don't do mammograms. I don't do pap smears as a rule. The other good thing is that our guys do not also seem to develop colon cancer. And so I don't put them through colonoscopies unless, again, there's a first degree relative that's got colon cancer and there's some reason. I certainly test for blood in the urine. And if that comes up positive or, you know, some other concerning symptom, I do. But in general, they don't develop colon cancer. So that's three things that we don't worry so much about in our population. But that being said, I always check my guys for testicular cancer because they do develop testicular cancer outside the age group that we normally check for. So my guys all understand that when they come in, I'm going to do a testicular exam because it's a concern to me that they develop those kind of tumors pretty regularly.
How about, my son just had his physical and we've always been, you know, so careful about who checks what. Do you check their prostate? Like, is that a thing? Because that's awfully invasive and that has not, at this point, I've always said to the doctor, we do not want to do that. That's a rectal exam for I'm sure every adult person here knows, but do you do that?
And even with, no, and even with neurotypical guys, that's really not recommended anymore.
Okay.
We just don't do that anymore. And I certainly don't do it with my guys. It doesn't seem to be an issue for my guys. At what age do I begin screening for testicular cancer? You know, every time my guys come in, I check them every time. And so it doesn't matter, you know, most of my guys, you know, I start seeing early, but I check them every visit. So they know that when they come in, that's something that we do. You know, I listen to their heart and their lungs and we do a testicular exam. So.
And I'm a pediatrician, but I would always tell the boys from when they were young, because most of them are checking themselves, that if you find a lump or a bump that you don't know what it is, to, you know, to make sure you let somebody know.
Yeah. It's a little hard. My guys hate to tell anybody anything about their private parts. And so it's a little hard, but I check them every time. So there isn't really an age I start because I start as soon as I see them.
Yeah. And I could ask questions forever, but I don't want to monopolize. I'm just trying to think of the common questions that we always get asked, but I want to make sure other people have an opportunity. We have about 10 minutes left. Does anybody else have a question?
Hi, I have a question about my daughter's 17, but I'm interested in her as she becomes an adult. About her, she has a period, and I was wondering if you had any recommendations for her to get on a birth control pill, or you know, what is your recommendation for girls that you know, don't want to have a period all the time?
Well, first of all, I recommend all my ladies be on birth control, and it's purely for their protection. I don't want them to become pregnant if they don't want to be. And I haven't had anybody that has wanted to have a baby yet, but you know, I don't know. But anyway, I talked to them about being protected. And I think even though the parents say, oh, well, they're always with us. They're always with us. Yeah, well, that may not be true all of their lives, you know. Then there's several options that you can do. You can do birth control pills and have a period every month. You can do birth control pills and have one every 3 months. There is evidence to say that you really don't need to have a period. So you can go on continuous. I've had patients go on continuous birth control and they don't have periods. I am not a fan of Depo.
Okay.
Because of the bone density issues that it causes. IUDs are good. Sometimes you have to use general anesthesia to put them in, but once they're in, they provide good protection, and you don't have to take a pill every day, and you don't have to worry about forgetting or whatever. And it provides good protection, and it's safe for people that have not had babies. The other is the Nexplanon, and that's the one that goes in your arm right
Okay.
here. It's good for 5 years, I think. We just put one in one of my patients yesterday, and it took 5 minutes, and she was scared, and then it was all over, and she said, oh, that wasn't so bad. And so that gives them protection for 5 years. Again, they don't have to worry about taking a pill every day, and most of those will stop them from having periods.
Okay.
Some of them, like the IUD and the Nexplanon, they may spot for a month or two, or have some periods, but we can take care of that. And then in general, they all stop having periods.
And what if, like my daughter can't swallow a pill?
Mm-hmm.
So do they have a liquid?
Mm-mm.
No. So you'd have to, can you crush the pill?
Yeah, I think so.
Are there still
Okay.
patches? Aren't there?
There's patches. Yeah. I
Oh,
haven't
there-
used them very often, but there's patches too.
Yeah.
It
You do
depends
have-
on whether your daughter would tolerate, some of my guys won't tolerate Band-Aids. And so a patch is not reasonable. I did put, not me personally, but I had my doc put a Nexplanon in someone's back because she was a picker. She didn't have Down syndrome, but if we'd have put it in her arm, she'd have destroyed her skin over that, because she'd have picked at it. So we put it back just under her shoulder, by her shoulder blade, and she has not bothered it, not time one, and she's forgotten about it. And so that's worked really well. If you've got somebody that is sensitive to that sort of thing, that you don't have to put it in their arm, you can put it somewhere else.
Okay. Thank you for your time.
Sure.
Appreciate
If
it.
a woman has congenital heart disease, one would need to check with their cardiologist, because some heart defects are such that you can't be on certain hormonal birth control because there can be an increased risk of blood clots. So, Moya,
And
I
I
don't-
did have a patient throw
Yeah.
a blood clot on birth control, and so we took her off, and had to go a different route. So it does happen, not very often, but it does happen.
Yeah, so check if you would need to check, obviously, your primary, but also with the cardiologist before starting hormones.
Okay. Thank you.
Oh, and yeah, it can affect all sorts of things. This Debbie says it affect her daughter's seizures. There are IUDs that are non-hormonal. There's one IUD that's a non-hormonal IUD. I think it uses copper, and so that's also a consideration if you want a non-hormonal kind of contraception.
Any questions from anybody else? I had a question about common skin conditions, the little pimples and boils and verging on abscesses, but not quite like any hygiene, skincare tips, pearls.
Have y'all heard of the Clorox baths? Do y'all do that?
We do that with Chris, and it does help a lot. Yeah.
That's the best way, or to take them swimming in a chlorinated pool. That also helps. It's the same thing. That's the best way to handle it. The easiest way to prevent them. Their skin is so dry that their pores stay open, and then the bacteria that's normally on top of the skin gets inside, and that causes the abscesses. So it's a real frequent thing. I think using an antibacterial soap of some kind, and then the Clorox baths is half a cup in the tub, and do that a couple times a week. A half a cup of Clorox or some kind of chlorine bleach in the bathtub, and let them sit in that for 20 minutes or so and splash around and make sure everything's covered. Helps cleanse the skins a little bit. And so, yes, that's exactly what it is. What we're talking about is hydrogenized superlativa, and it does help prevent that as good as we can. And then using an antibacterial soap on the other shower times also helps with that. But our guys are really at risk to develop those, and they develop them frequently. And it comes in those sweaty, dark places like under the arms and in the groin and those kind of places.
I just have a comment. My son also has boils, been plagued with it for years and years.
Mhm.
And honestly, we never did the bleach baths, or maybe we did it once, but his skin is so dry anyways. I would think we didn't do it because I'm thinking it's drying his skin out even more, you know? So one dermatologist told us to use Selsun Blue. So we've done that, but it didn't seem any help to help him that much. And another doctor just recently suggested doing Dial because it's an antibacterial.
It's an antibacterial soap. Yeah.
And-
There's also chlorhexidine, I think, soap that you can use. That's a good antibacterial, but Dial's good and it cleanses. I'm a little surprised about the Selsun Blue because those really aren't fungal, and the Selsun Blue is a antifungal kind of shampoo, and so I understand why that didn't help.
Yeah.
But the antibacterial soap probably would help more than anything. I think also a hard thing too is to keep their skin as moisturized as you can and use something greasy. You know, Aveeno or Eucerin or Kerry lotion or something, but a lot of my kids don't like to put it on, and so we have a hard time, but keeping their skin well moisturized is also helpful.
And also, you know, he's very independent and taking care of his hygiene and everything, but for some reason, I can't get him to shower every day. He'll forget. So we've been trying to really push that, and that in itself obviously seems to help his situation. And I think the Selsun Blue was like irritating his skin because one of the doctors like, I wonder if he's allergic to it. And here we've been using it for years, you know? So
I wonder if cooler showers too and not so hot might help, you know, not be so drying on their skin too, because hot showers are a little bit more drying than cool.
yeah. And he loves taking long hot showers, so that's not helping us either.
We're just talking about that.
Yeah.
Somebody asked when the ages begin testicular screening. Like I say, I do it, as far as I'm concerned, I would think anytime they go in, it ought to start. The neurotypical years for testicular cancer is 15 to 35. And so if you think about our guys aging a little prematurely, you know, I would start, you know, making it a habit around 10 or so, and make sure that those testicles are descended and that they're okay, and just so the kids get to understand that this is what happens when they come in.
I was just driving. I do that when I'm upset. Why are you upset? I told you. My daughter.
Do you have a question?
You just shot and killed him. No. So I would never hurt Jason.
I see, Maria, do you have a question? I see you're unmuted. Or
Oh,
any?
no, I'm sorry. I didn't realize I was on mute. Nope.
That's okay. I just wanted to ask.
I apologize.
Oh, you're fine. I just wanted to make sure everybody got a chance to talk.
I was in Sunday school one day, and one of the teachers asked me a question, and I told him I couldn't answer because I was muted. Because I did not know the answer to that question that he asked. So I said, oh, sorry, I must be on mute. So I've had too much Zoom, I think. Alternative to bleach bath for someone that only showers, no baths. Yeah, that's a hard one. I would use the antibacterial soap, the Dial or the Hibiclens. And those are both good. And then use a good moisturizer is about the best you can do if the guys don't get in the bath. And take them swimming. Maybe get them in the chlorine that way. It has a tendency to clear up in the summer because a lot of the kids swim. And so it isn't as bad in the summer as it is in the winter. So I don't know how many of you know, but I think there's also a gene on the 21st chromosome for wrestling. How many of you know about that gene? So a lot of my guys really enjoy wrestling and watching it and whatever. So
I have another question about leukemia. I've
Yeah.
read that leukemia is could be common for our kiddos, and was wondering, is there a special age for that, or is it all across the board?
you know, the incidence of that goes down when they get into adulthood. I don't know what age that crossover is, but I would think in the teen years, it's much more common. Laura, you could probably address that better than I could. It's much more common in the little kids.
It's usually young kids, like even before school age kids, I think is most common. It can be throughout childhood, but and I'm remembering all the kids that I've had with it, and they were all young,
Yeah.
like preschool age.
Any of the kids I've had, they had it when they were itsy, and now they're grown up and they don't have it.
Great, thank you.
Sure.
I have another comment, question. My son also got diagnosed with Raynaud's syndrome about a year and a half ago. And I was just wondering, I have an autoimmune disease. So, Dr. Brooks, who's at the clinic, she's very good, and she keeps an eye on him to see, how that's developing. Do you have any thoughts about that, or does that make him more susceptible of getting an autoimmune disease? And if so, which one? Or
No, I don't think it makes them any more susceptible to anything. We know that they already have autoimmune issues. Hypothyroidism is an autoimmune issue. Rheumatoid arthritis is an autoimmune issue. Type 1 diabetes is an autoimmune. So we already know that they have some autoimmune issues. But to say that Raynaud's makes him any more susceptible, I don't think that's true. I think it just happens. It is, in case you're wondering, and nobody's asked, which I was always surprised, we're still recommending the flu shot and the COVID booster for our guys. It's still important. I worry, my guys did really well. Here in Kansas, they did really well through the pandemic. But I'm recommending the flu shot and the COVID booster for all my guys as well.
Alberto Costa is an expert researcher on Down syndrome who has a child with Down syndrome, and he was at our DeSanio's medical advisory board, and he has some access to data before it's published, and it showed after the people with Down syndrome got booster shots that their immune response was actually the same as people without Down syndrome. So
That's good to know.
It is, the vaccines do work in people with Down syndrome. And he had spoken to a colleague, I think Dr. Chicoine, who said that their experience with Paxlovid was very similar to people who did not have Down syndrome. So
yeah, I don't think we've seen any difference in my clinic anyway. The kids did fine with the vaccines. And they did fine. If we put them on Paxlovid, they did fine with that too. So
I have another question about the COVID vaccination. Well, actually, if you catch COVID, if our kids catch COVID, do you recommend putting them on that antiviral medication?
yeah, that's the Paxlovid. Yeah. Yeah.
Or how
I think
mild it seems like it may be, or like the first couple of days, it seems very mild. Should you still get on it right away?
It's kind of your call. If you would feel safer putting them on it, that's okay. Kind of the one side effect I've heard from it is that it makes a really nasty taste in your mouth that's there consistently while you're on the medicine. If you feel like your youngster's handling it and it's not getting any worse, you have I've heard 5 and I've heard 7 days after the diagnosis that you can still start it. And, you know, by 5 to 7 days, you should know whether he's getting worse or not. And so I think it's your call on whether or not you want. I've had patients that, you know, did fine and didn't need anything else. I've had patients that took it and did fine. So it's kind of the same way with neurotypical patients. You know, my son had it, got exposed to COVID, and he said he felt worse on the Paxlovid after 2 days than he did just having the COVID. So he quit taking it and did fine. My husband had COVID and he took the Paxlovid and he felt fine. I mean, he did fine. So it really is very individualized, and it's your call. And I don't think there's anybody that would fault you either way.
I'm sorry, is the Paxlovid the antiviral or?
Yes.
Okay. I was
Yeah.
thinking it was
Yeah, it's the antiviral for COVID.
Okay.
And I want to thank Moya. I want to thank Global and DeSanio were able to coordinate. So Global has sent us printed copies of the family-friendly guidelines that DeSanio will be mailing to everybody who has a child 18 years and older during October for Down Syndrome Awareness Month. And I really urge you, I've read it and it's wonderful, and take it with you to your provider, and also go on the website, look at the toolkits, look at the checklist, because that's you can print that out and also take that to your provider, because some of these things, no matter how good your adult provider is, and if you're their only person with Down syndrome that they see, then they might not know some of the small details. Also, just check out our website, check out our new medical section. We also have research opportunities on there, and we're going to do a Facebook post. There's something called Trial Ready Cohort Down Syndrome in Cleveland that it is just getting people ready and examining them, doing different collections of blood work, imaging, physical exam findings over time to try to find out more about Alzheimer's. But there are many other studies that people are recruiting for too. So if you're interested in your person participating in research at all, please look at our website. Or if you want any resources, we added a whole new medical section. And if you need any resources, please feel free to email me, and I can try to find an expert for you or find a resource for you.
I think you can get onto the Down Syndrome Medical Interest Group website as well. I think that some of that's open to the public with some articles and things if you're interested in reading that stuff too.
Yes, and Global has many webinars. If you're not on their mailing list, and LuMind also has a lot of great webinars. So those are also
I'm
ways.
going to one October the 6th for Global. I think it's on dementia. They always have good webinars.
Yes. Moya and I are happy to answer questions, but please always consult your own physician, because we don't know your child and can't give you.
Yeah, and like I said, these guidelines were written so you can, I mean, if you run a copy of them off and hand them to your doc, you know, he'll be able to know what to do with them and decipher all the terms and whatever. But that's why it was written the way it was, so that you could take it to your doc and say, here's the stuff you need to know about my kiddo and what you need to do.
Okay.
All right. Thank you very much.
Thank you, Moya. Thank you so
Sure.
much. It's been a pleasure meeting and talking with you, and thank you everybody for coming. And I'm very pleased with the turnout. Thank you all.
Thank you.
Thank you.
Hey, Laura, I'll write Brandon, make sure that it's okay to release those slides, and then I'll send them to you.
Okay. And
Okay.
anybody who wants the slides, please email me. If you've responded by email, then I'll just send them out to you. But some people who are on Facebook, I might not have their emails.